back again. I have slide envy from our last speaker, unfortunately. Mine are a bit more plain than that. So I'm going to actually carry on from a little bit of what Colin's been speaking about into post-cardiac arrest management. And I've actually, right from the word go, I've made my first mistake in the first slide, because we're not talking about in the PICU. We're talking about what you can do, again, in the context or in the setting of the patient coming into your emergency department while you're waiting for the retrieval team to respond. So it's really more geared towards that side of things. I'm very glad I wasn't on that retrieval. That was just discussed. But pediatric cardiac arrest is thankfully fairly rare. It is very traumatic for everybody involved, not least the patient, and unfortunately has very poor outcomes still, as most cardiac arrest patients still have. I've just put together a very general sort of case just to pick up a few things to sort of introduce it, but we're really going to go through a systems approach to how you can potentially improve the outcomes. So we have an 8-year-old male, previously fit and well, who's had a 4-day history of fever, quite high fevers. Parents have been concerned. Sore throat, generalized aches and pains. Later in the duration of the illness, complaining of upper abdominal pain and not looking overly well. Seen by the GP initially, who felt they had a sort of a strep throat type picture, antipyretics and antibiotics. Day or two later, then the child's really not making any progress at all, no improvement with the treatment from the GP. They're lethargic. Parents notice that their work of breathing has really, or they say, oh, his breathing sounds funny, and he's just hot all the time, and he's an awful colour. And while they're getting ready to bring him up to hospital, he collapses at home unresponsive. And the parents who are very clued in, aware parents check and realise that he's not breathing, and they start CPR and call 999. So the paramedic team is there within 10 minutes, which is very impressive. And they confirm cardiac arrest and continue CPR, and they confirm that it's a PEA arrest with a sinus bradycardia on the monitor. They ventilate manually, try to insert an LMA. They're not going to try and intubate. They put an IO line in, give some adrenaline, no response, and essentially scoop and run, which happens quite often, and come into the emergency department with CPR ongoing, phoning ahead as a standby call. So everybody in the emergency department in the nearest DGH immediately goes into overdrive and panic, as often happens. But actually they do a really good job of managing things. So in the ED, resuscitation is continued again with confirming that there was loss of circulation. The patient is intubated by the emergency or the anaesthetic team. They give a fluid bolus through the IO, which is still working well, and continued running down the normal algorithm. And the very astute anaesthetic reg notices that after the fourth dose of adrenaline, while they're still doing CPR, the end-tidal CO2 monitor suddenly spikes and starts reading a much higher level. And when they get to the next pulse check, they confirm that there's return of spontaneous circulation. But the observations are somewhat like this. So you've got a tachycardia, you've got a BP of 55/20 when it actually measures on the non-invasive, and the best SATs they can pick up are around 88, and the child is not making any significant respiratory effort. The pupils are sluggishly still reactive. They're about size 4, and they've got a venous blood gas, which is alarmingly similar to the one that was described in the last talk. So I think we've covered that already, but it's not good. I think everything's wrong with that gas is one way to put it, as somebody else said. But there's a significant severe lactic acidosis with a little bit of increased CO2 as well. Actually, the CO2 is a reflection of how well they've been managing to ventilate the patient. So, a few other investigations carried out. Chest X-ray shows significant cardiomegaly, and the lungs look very wet. So, what do we think about this sort of patient? What do you think is the most likely diagnosis? Any thoughts? Yeah. Yeah. So it's in fact probably an infective myocarditis. Could be some kind of Coxsackie virus, maybe flu, any number of those sorts of things. So that would be top, or certainly top of your list. One of the comments about that sort of patient is you're very lucky to actually have been able to manage to resuscitate that patient, and that's probably reflective of good quality and early CPR. So what I want to go into, we're not going to run an APLS course. What you need to think about is, what are your priorities now? So you have got return of spontaneous circulation in this patient, and everybody's pumped up about that, and it's great, you've got the patient back, but that's really only the start of the process. And there is a lot of work that needs to be done to give this child the best opportunity of a good outcome, which is very rare, unfortunately. So you need to be thinking straight away, how can I optimize this child? And again, it's to try and encourage you guys to think about what way you need to do this. You'll obviously be talking to the local PICU, the Retrieval Team, for further advice, but what sort of things can you implement yourself in your emergency department, or by transferring up into your own ICU or even adult ICU? So, not surprisingly, having no circulation for a period of time and then suddenly reperfusing everything, even if you're reperfusing it quite badly, is not good for your body. And that results in what has generally become known as post-cardiac arrest syndrome. And there are three main components that we would include in thinking about that, the three priorities of management. So the first of all is the brain injury. The second part is the subsequent myocardial dysfunction. And then thirdly, you've got a systemic, so you've got to think about the rest of the body, in total body ischemia, and then reperfusing all the organ systems is going to cause a significant inflammatory response. Okay, but on top of that, don't forget about what caused the arrest in the first place, because there are maybe other treatment priorities to think about with that. And this child, we'll talk about myocardial dysfunction, but that's going to be top of your list of one of the important things to get on top of. Okay, so quickly going to talk a little bit of pathophysiology about each of those. So the brain injury is the main cause of significant mortality, but also morbidity in survivors who make it through with a bad functional outcome after cardiac arrest. And this is an area of a lot of research at the minute. You've probably heard of the paramedic study that was done recently looking at adrenaline dosing, and it was totally misinterpreted in the newspapers by saying adrenaline causes brain injury. Well, that's nonsense. It doesn't. Adrenaline resuscitates patients, but we can't tell which ones are going to get bad brain injuries yet. So we still should use adrenaline in resuscitation. But it's the particularly in children where they have healthy hearts, you resuscitate them, but they have suffered a significant hypoxic ischemic injury to the brain. So, and there's multiple reasons to why the brain doesn't tolerate ischemia well. It triggers neuronal necrosis and apoptosis. When the circulation is so sluggish, the microcirculation gets clogged up with little thrombi, and then you get a hyperemic reperfusion trying to get its way through that. You end up with cerebral edema and potentially raised ICP. And on top of that, the autoregulation goes out the window, so the brain has no concept or is unable to regulate its circulation again. So you can have clinical manifestations anywhere from coma and reduced level of consciousness through seizures, myoclonic episodes. You can have cerebral infarcts and spinal infarcts, and eventually, or most severely, brainstem death. The important thing about post-cardiac arrest brain injury is that it occurs over hours to days after return of circulation. So in some ways that makes you think, well, actually there's a big window of opportunity to try and intervene here and see if you can optimize things and try and slow down that process. It's not a all immediate insult. It progresses, so therefore it should be interventionable. It's also exacerbated by things like fever, uncontrolled seizures, hyperglycemia, oxidative stress. So that kind of gives you the answers for some of the questions later on, so you might want to write those down now. Okay, secondly, myocardial dysfunction. This, if it's seen early after post-cardiac arrest, is associated with a poor functional or poor survival outcome and poor functional outcome. So it tends to happen very early. It usually hits its nadir around 8 hours following post or return of circulation. Children tend to get it less severely than adults, and again, that's probably a reflection of underlying healthy myocardium as opposed to elderly patients on a Western diet with dodgy coronaries. So they don't get it as severely. That means if it is problematic, it is very severe. And actually within 24 hours, you can come back to nearly normal function again. So it does recover quite quickly, and again, more so in children. Depends on the underlying pathology. Our case, I wouldn't expect his myocardial function to come back to normal very quickly, because that's part of the reason why he's had this episode in the first place with his myocarditis. So you need to be thinking along those lines. But even in that 24-hour period, that's enough to cause significantly further damage to the patient. So again, you need to intervene and try and stop that. It's a global stunning phenomenon. It's not, as in adults, to do with coronary circulation and ischemia, things like that. So that's why it will recover, but it will respond and is sensitive to appropriate vasoactive support, or appropriate inotropic support. So you can fix it if you use the right medications. Again, depending on how severe it is. And we've had a discussion of a case already where they need a huge amount of inotropic support and are eventually onto ECMO. So that's how severe it can be. And then everything else, basically. So every other organ system in the body becomes ischemic and hypoxic, and then suddenly gets perfused again. So it's the most severe form of shock you can have, really, and that's only partially restored during CPR. So the body then, there's a compensatory mechanism to strip as much oxygen out of the blood as possible, which means then when you get circulation back, even if you're giving high flow oxygen, there's a significant oxygen debt to recover. So the patient is still hypoxic, essentially, during that recovery phase. And you've got the cardiac dysfunction on top of that, so your blood pressure or your perfusion may not be that great. On top of all of that, it basically triggers off every immune and coagulation cascade in the body, so you essentially end up in a circumstance that looks like SIRS. It looks almost like sepsis, but with that initial cardiac dysfunction. And you can get adrenal suppression, and you can get impaired vasoregulation. So again, it's a dynamic process. You go from a cardiogenic looking picture sometimes to a very SIRS-y septic sort of looking picture because of the reperfusion injury. So, and just kind of looking at the different phases, if you're going to if you're planning interventions or looking at how to intervene in this sort of there are period, you've got the immediate early sort of phase where you should be limiting ongoing damage from that reperfusion syndrome. Then there's some slightly longer term things before you get into the recovery period. At all times, you're looking at preventing recurrence of whatever the initial insult was, but you're not really getting into prognostic sort of goals until after about 72 hours. So early on, it's limiting damage as much as possible. So how are we going to do that? What sort of things? Thinking about our case that we had already, and some of this has already been covered in the last talk. This child was intubated in the emergency department by the local team. What recommendations would you give to them when you're putting the tube in? What would you think of? And we've sort of discussed that already. What type of tube? Cuffed, yeah. So this child is probably going to develop ARDS, or at least pulmonary edema, so you're going to have high pressure ventilation, so an uncuffed tube is going to be difficult. Put it orally. You don't have to put it in nasally. They'll probably bleed everywhere if you do, if they're coagulopathic. So an oral, cuffed, appropriately placed ET tube is essential afterwards if the patient stays in the same condition that they are. So the right size, the right distance in, not too far, not down into the right main bronchus, so check it with a chest x-ray. You've got return of circulation, and sometimes, now in this case the patient was tubed before that happened, but occasionally you're still ventilated because intubation is less on the resus algorithms now. You may be trying to ventilate through a laryngeal mask, and you then have to intubate the patient after return of circulation. So again, I really like that term, the least uncardiac stable induction agents you can use is a very good way of putting it. So you want to use something that's going to maintain your blood pressure, maintain your heart rate, so things like ketamine and the appropriate muscle relaxant. You really don't want to have any vagal stimulation while you're tubing the patient, which will make them bratty, and they will just spiral out of control again. So think about things you can give to maintain that. Ketamine's good, but also think about atropine. So this patient is now in your emergency department, intubated, return of circulation, blood pressure's pretty awful, SATs are not good, you're going to ventilate them, you're ventilating, your anaesthetic team are there, goals and targets for ventilation. So what we're trying to do now essentially, unless the patient is grossly unstable, as the one which was discussed previously, and their ventilation may well get worse as any lung injury gets worse, you want to aim for a very set, standard set of criteria to help with cerebral perfusion, okay? So you want to aim for a normal CO2, unless this is a child who for some reason has an elevated CO2 chronically, or there may be some young children with chronic lung disease. You want to avoid really high peak pressures, as we talked about previously. So you're trying not to thrash the lungs completely. If the lungs are so stiff and uncompliant that you can't ventilate them with pressures that are staying under 30, 32, you need to think about an alternative form of ventilation, like high frequency. You want to avoid massive tidal volumes. So small tidal volumes for stiff lungs that are now filling with fluid, so 6 to 7, and that's as the standard sort of ARDS type thinking. Difficulty with that is if you've got a small tidal volume and you want to ventilate to normal CO2, then you're probably going to have to use quite a high rate, and that may make it a bit challenging. So again, you have to think carefully about your ventilation. And in the DGH emergency department, you're not going to have access potentially to a high frequency oscillatory ventilator, so you try to do as much as you can with that, but those are the sort of targets you should be thinking of. And then something that's coming in more recently is don't over-oxygenate them. Now, we said this child was hypoxic in high flow oxygen, but once you get them ventilated, maybe if you've got some PEEP on, your oxygen SATs may well come up. You don't want to have SATs sitting around 100. You're not likely to, but if you do, you're probably giving too much oxygen, and actually that is potentially harmful to the patient. So target your SATs 92 to 96, and if it's 92, that's absolutely fine, okay? You don't have to overdo it. Use your PEEP to optimize your oxygenation without giving too much that's going to cause really high interthoracic pressures, okay? Now, sorry, this is a really wordy slide, apologies for that. There's quite a lot to talk about. We'll come on to circulation. So our patient was profoundly hypotensive for an 8-year-old. So you need to optimize the cardiovascular status as soon as possible. If you have the facilities to do it, an arterial line is lovely, a central line would be lovely, but we talked earlier on, you can do this peripherally, you can use an IO needle, which the paramedics have already put in. Central line gives you a few other wee tricks like central venous oxygen measurements and things which will tell you if you're trending in the right direction. But they're not essential, but they are useful, and they certainly will be put in when you come into ICU. You'll need a 12 lead to try and look at if there's any underlying rhythm problem as to why the patient has arrested, and echo if available. And we talked earlier on about focused cardiac ultrasound or focused echo, which can be very useful in these circumstances. It'll tell you, you can put the probe on and see whether you've got a big, baggy, failing ventricle or a big cardiac tamponade, which obviously are going to have different, or if you need additional fluid filling. Okay. And then you want to optimize cardiovascularly, so cautious fluid administration, inotropic support, because again, it's myocardial stunning. But they may develop a need for a vasopressor later on, but again, we'd go with adrenaline or dopamine in the first instance as that inotropic start for the myocardial stunning effect. You can overdo it with vasopressors, as we said previously. If you're squeezing too hard on a failing ventricle, you're actually going to make it worse, so just be careful about that. What kind of mean arterial pressure are you going to target? Well, there isn't actually a lot of good evidence for this. There have been a lot of studies looking at reasonable or sort of normal blood pressure, elevated blood pressures. Outcomes are never really definitively different. But what you do need to think about is your cerebral perfusion pressure. So if you're assuming that the brain is going to be a bit swollen and tight after this, you need to ensure that your mean arterial pressure is enough to provide decent cerebral perfusion. So you may want to push your map above that, and there are calculators and things that will give you details for that for individual age groups. Measure your lactates. I know there's lots of conflicting evidence about that, but generally a lactate that's going down isn't always a bad thing. Measure your urinary output, so catheterize the patient. ECMO would be lovely if it was readily available. Well, it's not lovely, but it's pretty catastrophic. But mechanical support isn't readily available over here, so we tend not to be able to put patients onto ECMO as an emergency life support measure. But in some areas that is possible, but it's going to be it's not going to be limited, or it's not going to be available in Northern Ireland, unfortunately. So I wanted to dwell on that hypotension a wee bit. And actually there is, I mean, it's like one of those things, the patient's hypotensive, so we should treat that, otherwise they're going to get worse, duh. Well, actually, we like to have evidence for these things. So the THAPCA trial actually was a trial to do with theraputic hypothermia, which was published a few years ago. I'll come back to that, the actual primary trial in a minute or two. But they actually did a secondary analysis of the patients. And what they found was that any early hypotension, so if you had any significant hypotensive episodes in the first 6 hours after return of spontaneous circulation, your survival chances went down quite dramatically. All hypotension up to 70 hours wasn't associated. It's that early phase, and it didn't matter whether they were cooled or not, which is what we'll talk about in a few minutes. They did, if they were hypotensive, they did worse. Okay, so it's important to get on top of that and treat it as soon as you can. So you should be looking at getting peripheral inotropes started, or centrally if you have the facilities to do that, or interosseous. Okay. So neuro-wise, disability, since we're going through the ABCD kind of approach. So again, we've talked about a little bit of this already, but you really want to institute what we would describe as neuroprotective strategies. They're assuming that there's going to be some cerebral edema and there'll be potentially raised ICP. So don't keep the patient lying flat. If their blood pressure will tolerate it, and because you've started your peripheral inotropes, it will, you can set them up. Okay. If it's a potential trauma, obviously you want to protect the C-spine, but you can put them up 30 degrees head up. It will improve venous drainage, it will reduce the risk of cerebral edema getting worse, it'll potentially reduce ICP. And push your cerebral perfusion pressure with your cardiac support. Keep them normocapnic, as we've already said. But on top of that, think about your sedation and potentially paralysis. So in some district general hospitals, it's one of the things that will happen is the patient will be moved to a theatre area where a lot of this will have happened. And they may be kept asleep with a volatile anesthetic agent on an anesthetic machine. That's potentially not good for cerebral perfusion because it causes cerebral vasodilation. So we really should be thinking about sedation, and we tend to advocate a benzodiazepine plus or minus an opiate. The benzo will help reduce seizures, which is important, and doesn't have such a significant effect on cerebral blood flow. On top of that, you don't want them shivering, things like that, so sedate properly, plus or minus muscle relaxant. The difficulty is if you paralyze the patient, you're masking potentially seizures. You need to look out for that. Now, in the intensive care setting, we'll use sort of mini EEG type things, or have an EEG, formal EEG done, but otherwise you're just going to have to look for any signs of seizures ongoing in the paralyzed patient. So regularly check the pupils, look for any spikes of heart rate and blood pressure. And if there is evidence of seizures, treat them. So you're probably on benzodiazepines already, but phenytoin possibly. Very, very cautious use of thiopentone for refractory seizures because it is extremely cardiodepressant. It's not good for your blood pressure. So only if you absolutely have to. Okay. And then kind of some of the other points I want to get to again, thinking about the things that you can intervene on. Temperature regulation, environment and everything else essentially, but temperature regulation. So post-cardiac arrest, even out of hospital arrest where they've been lying somewhere and they're cold because they've been lying on the floor and somebody's been trying to do CPR. Once the children get into hospital post-cardiac arrest, they frequently will spike a fever. And it's much more common in children than in adults. And there are multiple studies that show that if you have different looking at different endpoints, but essentially if you have a temperature greater than 37.8, is associated with increased in-hospital mortality following cardiac arrest. And as we know, pyrexia is more common in children. So you need to aggressively treat pyrexia, okay? Don't let them get hot. Which leads to the next natural question, well then, do we just cool them, keep them cold? And anecdotal stories of people surviving in frozen lakes and things are come bouncing out at that point. So this has actually been looked at. It's been looked at in adults a lot. There were a couple of big studies, but unusually there is actually a big study carried out in children, which was called the THAPCA. And there was 1 or 2 people involved with that, because recruiting adequate numbers for a study like this needs to be carried out over multiple different, I'm not one of them by the way, I wish I was, but it needs to be carried out over many, many centres because the numbers are quite small. Sorry, that probably doesn't project very well. But the results were essentially, they looked, so it shows you they were randomized to hypothermia or normothermia, and they looked at survival with a good functional score. So there's the VABS2 is a neurobehavioural functional score. They looked at overall death, and they also looked at how their functional score changed as a secondary outcome changed over the first year of their survival. So looked at a whole lot of different endpoints. And the take-home message was that there was no significant between group difference in primary outcome, which was survival at 1 year, with a good neurobehavioural outcome between the hypothermic and the normothermic group. And the hypothermia was targeted to 33, 34, and normothermia was 36. All-cause mortality at 1 year was no difference, and there was no significant difference in the neurobehavioural changes or the scoring changes over the year of for the survivors. So the take-home message now, people have gone into it in more subgroup analysis, and they're trying to tease out that there might be something with regards to maybe slightly cooler, but it's non-significant at the minute, so we can't really accept it as reliable treatment. So what you should do, the take-home message to me is treat the pyrexia, but you don't need to cool them, but you have to keep them normothermic. So using those cooling blankets and cooling equipment that everybody then invested in is still useful, but you just maintain them at normothermia. Okay? And again, those are things that can be acted on in the emergency department or in the DGH. So sometimes we'll arrive to receive or to pick up a patient on retrieval who's post-cardiac arrest, who's cold, and there's a warming blanket on them. And it's a natural, you get a child and one of the natural things is avoid hypothermia. Well, we're trying to avoid hypothermia here, but you don't want to heat them up. So don't worry about warming blankets and things like that, okay? Other simple things, glucose control. So hyperglycemia is bad, and it's very common in pediatric patients in PICU. It's common after cardiac arrest. Again, you don't need to be tight control with it. So there are many studies looking at that. The Winterguest one is more an overall PICU study looking at hypo and hyperglycemia and outcomes. So you really want to control your blood sugar, keeping it 8 to 10 at absolutely the most, and 10 is probably pushing it a little bit. You should be at that point thinking about starting some insulin. But you don't need to be sitting really tight with it, because all that essentially does is risks you developing a hypoglycemia, which will be more damaging as well. So, but again, these are things you could potentially think about starting while you're waiting for the transport team to arrive. So don't let them get ridiculously hyperglycemic. We mentioned adrenal insufficiency previously as well. That seems to be common after cardiac arrest. The adrenal glands are pumping out everything they can following the post-arrest syndrome, but there's no evidence for a benefit in giving hydrocortisone in the post-arrest period. I would say unless you have refractory hypotension, and then I think it's absolutely, I would definitely go ahead. But just as a routine thing, this patient's arrested, I'm going to fire some hydrocortisone in. Post return of spontaneous circulation, there isn't evidence to support that, so you don't need to worry about that. There is a there is a good reason for doing all these things. As we say, prognosis is generally bad in post-cardiac arrest. The PICU care subsequently can be very prolonged for some of these patients, and one of the big difficulties is knowing which patients are potentially going to do well. And there are so many factors involved with that, to do with their pre-morbid condition, how good the resuscitation was, but a lot of those post-resuscitation factors we know are modifiable, which we can do. But this is a significant difficulty because we don't know we have no idea, not necessarily just for survival, but we don't have any prognostic scoring way of predicting what their functional outcome is going to be after all of this as well. So there are a lot of studies, there are several studies going on at the minute actually, the NEPAC and NeuroPac, going through the PICANET system, which is the National Paediatric Intensive Care Audit. So this is something that's going to be looked at in a lot of detail, and that might then guide the duration or suitability of supportive measures after initial resuscitation. That's more for us in PICU. Some of the things that are jumping in as well are like early CT brain might be able to be interpreted with some information regarding prognosis. So again, that can be something that if the patient is stable enough, you might be able to go and do that, but if they're not, it's not the end of the world. Okay. So again, what I've tried to talk about, or what I wanted to bring to you really, are things that you can do in the DGH setting where you've resuscitated a patient successfully, which is always a great achievement, but then think of all the things you can do potentially to try and improve the outcome. So just summarizing it all, pre-PICU measures that can be helpful would be trying to ventilate the patient well, avoid overdoing it with the oxygen and keep the CO2 normal, avoid that early hypotension, so get in there with your peripheral inotropes, give the right sedation, do your ICP managements and your seizure controls, and normothermia and normoglycemia. I haven't mentioned electrolytes and things like that because it was sort of covered in the last talk, but again, you'll be wanting to keep a close eye on your sodium as well for things like diabetes insipidus post-arrest and your urine output. Okay, so